Thank you very much for the invitation to diagnose the ARDS or discuss what a new definition could look like. I think it's a very interesting and exciting time to do that. My conflict of interest are listed on the next slide. I'm working with a number of companies to get equipment or research grants. And we always have been struggling for having a clear definition of ARDS, because there's a kind of dissociation between what we have in mind, which is clearly illustrated on this X-ray, where there's something diffuse, there's something alveolar leakage, and everybody would agree. But when it comes to having precise diagnosis, that's more a problem, because there are many patients who do not look like that, and who still have this diffuse leakage. So the last definition, which has really been useful in a number of trials, was elaborated by a task force who met during the ESICM meeting in Berlin, so the Berlin definition, and was published in two papers, one in JAMA and one in intensive care medicine. And this is the main points of the definition. The timing should be within 1 week, the chest imaging, bilateral opacity, the origin of edema, which is not cardiac failure or fluid overload, and this new classification in mild, moderate, severe based on the PF ratio, with two objectives. One was to be sure that the patients who have mild ARDS are still considered by clinicians as having ARDS because they need lung protective ventilation. And the other objective was to improve the stratification into clinical trials. And there was a lot of discussion about the PF ratio or any oxygenation index, saying it can be modified by the PEEP, by the FiO2, and there was no good definitive way to address that. The only point is that when we try to validate this definition through different databases, mostly of randomized trials, almost all patients were already on PEEP 5. So we added this notion that the PEEP should be at least 5, which has been a problem, as I will discuss soon. So since this definition, we have new data. I would say one important landmark has been the LungSafe data. It's a kind of snapshot of what is ARDS and how it is managed in ICUs all over the world. So you could certainly argue that we cannot say this is really a fair representation of every ICU, every country, and that's for sure. But at least it's something, and it has been very useful for describing the epidemiology, looking at how patients change in terms of category, looking at the effect of different techniques, and looking at risk factor and management. So these data are important, and if we go forward, we should use it for maybe thinking of the new definition. So the first point of LungSafe was, is the Berlin definition working correctly in terms of this classification into 3 groups? And broadly speaking, the answer is yes. It works okay. You see the clearly different outcomes of the mild, moderate, and severe. So that was a confirmation that it seems to work well as a way to stratify the severity of the patients. But the big surprise of the initial study was to discover that a lot of patients who had hypoxemia, who had bilateral infiltrates, who had rapid onset of the disease, were not recognized by clinicians as having ARDS for whatever the reason, and maybe because the clinician did not think it was important, but look at the mild category, only 50% of the patients were classified as having ARDS, and in the severe group, more than 20% were not recognized. And this seems to matter because the way the patients were ventilated, like tidal volume and PEEP, was different whether they were recognized as having ARDS or not. So that's a kind of failure of the definition in terms of the clinical use. Another example of a kind of failure is the use of non-invasive ventilation. You could expect that it's less and less used the more severe are the patients. But first, the PEEP issue was a problem because you cannot speak of ARDS if the patient has no PEEP. And second, you see the percentage of use of NIV in the mild, moderate, and severe, it's the same. So let's say clinician did not use the classification to say, well, we should treat this patient differently. And the big factor which started to appear at the time of the LungSafe, but which became very clear in the last decade, is the use of high-flow nasal cannula, which in many studies have been shown to have benefits in hypoxemic respiratory failure. And this is the Florali study from Jean-Pierre Fratt and collaborator. And you have here the cumulative incidence of being intubated, very, very significantly lower in the high flow group. The point is that these patients with bilateral infiltrates, often with severe hypoxemia, could not be qualified as having ARDS because of the lack of measured PEEP. And another big issue which we are still living is the pandemic, the COVID pandemic. And there are many debates about the COVID pandemic, but one of them was, can we classify these patients with ARDS? If you look at the average time from symptom onset to ARDS, it's on average about 12 days. 12 days is more than the 7 days required by the Berlin definition. So from this criterion, we could not classify this patient as having ARDS, which for all of us, I would say, probably does not make sense. So recently, Michael Matte, Taylor Thompson, and Lorraine Ware published this commentary saying maybe we should revise the Berlin definition to be sure that patients receiving high flow nasal oxygen can be included. So that may need to change the PEEP definition. And Michael Matte has already started with a large group discussing what could be a new definition. And one important point I'd like to address now is this question of the chest X-ray. And there are different ways to look at it. One of them is the data we got from LungSafe again. And as you may remember, LungSafe looked at patients who were hypoxemic, whether they had unilateral or bilateral infiltrates. And when we compare the outcome of patients with unilateral infiltrate versus the ARDS, bilateral infiltrate, you see they seem to be less sick. The survival is clearly worse for ARDS. However, when you look only at those with two quadrants, so bilateral two quadrants versus unilateral two quadrants, you can't find any difference. The survival is exactly the same, the duration of ventilation, etc. So suggesting strongly that maybe this group of patients should be included in the same group of hypoxemic respiratory failure / ARDS. And honestly, this may be a difficult task. We all know that we have seen patients who look like being really unilateral on the chest X-ray, but looking at the CT, there was also infiltrates and consolidation, which were hard to see on the plain imaging. So is the new ARDS definition should get rid of the need for bilateral infiltrates. That's probably shocking for many of us. But think about it again. This is a series of X-ray which have been published with the ICM paper of the Berlin definition, and they are classified as being compatible with ARDS, non-compatible, mostly atelectasis or fluid pleural effusion, or equivocal, which means we are not sure. And when you ask clinician, the agreement between clinicians is very poor. Shannon Goddard with Gordon Rubenfeld and Eddie Fan in Toronto did a randomized trial at the time of LungSave to try to offer an education and mostly a video discussing the characteristic of a chest X-ray compatible with ARDS. And the result comparing the intervention group who received the education program versus the control group is totally negative. There is no improvement. The diversity of response is completely the same with or without the education program, and they did a number of sensitivity analysis to show that it was very consistent. So maybe we should get rid of it. And lastly, as clinician, you know that I think most of us would say, well, there is something in the middle lobe because you still see the edge of the heart. But many of us will probably forget that there is also something on the left lower lobe. And so making the difference between unilateral and bilateral infiltrates quite difficult. So is the solution to make the chest X-ray reading very, very detailed and precise using, for instance, the RAIL score? Probably not for a definition. This can be very useful, but not for a definition, especially when we have an under-recognition problem. And maybe the pediatricians showed us the way. They say we should simplify the definition, eliminating the need for bilateral infiltrate. They also say we should use pulse oximetry when PaO2 is not available. And we have many data showing that we could use SpO2 FiO2 instead of PaO2 FiO2, which can facilitate the detection, either because you don't have ABG right away in the emergency room or at the time of the assessment, or because you are in a place where you don't have ABG machines everywhere. The only thing, if we think of removing the notion of bilateral infiltrates, is probably to ask for 2 quadrants, because there are so many patients with only one left lower lobe infiltrate that this may not be a good idea. But instead of the X-ray, we could maybe use the lung ultrasound, at least for 2 reasons. One is that some of our colleagues are now becoming very expert in that technique, and they may be very good at detecting the consolidation, as illustrated here. And the other reason, again, is that there are many places in the world where it's easier to have lung ultrasound than chest X-ray. And this is exactly what was done in this Kigali modification of the Berlin definition. So in Rwanda, where difficult to have ABG and difficult to have a chest X-ray, much easier to have the ultrasound. There are many other points we could discuss, like, for instance, introducing the level of PEEP into the definition, very, very nicely done in this study recently published, which seems to improve the prognosis capability of the PF ratio. It was called the PFP ratio, and that's something which could be considered. So new ARDS definition, yes, we need it, and we need to discuss the timing. We need to discuss this issue of the PEEP. We need to change our approach to imaging in general, and we may need to think of something more accurate for oxygenation. Thank you very much.